What a beautiful day. I'd like to welcome everyone that's here to our Kidney Cancer Symposium. And it's really a celebration. And this celebration was really inspired by the Andy Durr Foundation. The Durr families, was right here. And first of all, I'm Suresh Nair. I'm physician chief of the Lehigh Valley Topper Cancer Institute. I'm so excited for so many reasons. First of all, we haven't had a live celebration. We have this every year since 2019. So it's been 4 years since we've been able to commune like this for our kidney cancer survivors, their families, our staff, our caregivers, our community supporters, to all really come and embrace each other and support each other. And last Thursday, we had a similar celebration for melanoma survivorship. And both of these events have just really, I think for the staff, many of whom are in the middle here, it's like a shot of adrenaline for all of us because, this is really, really wonderful. And then today, what's really nice is we're all here celebrating with our survivors. I thought the group photos, fantastic, all of us being together. And for me, I've been an oncologist now for 33 years in the community. I was very fortunate to train at University of Pittsburgh in my hematology oncology fellowship. And our speaker, Dr. Mark Ernstoff, has been really my inspiration, my mentor, my whole career. When at the time that I arrived at University of Pittsburgh in 1987, I had trained at Jefferson for medical school, did my residency at Geisinger. Was really influenced by some of the leukemia patients I took care of. Went to Pittsburgh to be a leukemia doc, and University of Pittsburgh at that time had just the year before had become an NCI cancer center, Pittsburgh Cancer Institute, and a whole group of really brilliant physicians, researchers came from Yale. Dr. John Kirkwood and Dr. Mark Ernstoff were my mentors, and they were the leaders. And one of the most amazing things is, 1987, for many of us doesn't seem that long ago, but yet it is so long ago. And Mark and John, back then, they were such visionaries. They knew that the immune system was the key to curing cancer. I remember going to ASCO meetings, and you hear presentations that weren't all that encouraging for the absolute results. And all the fellows, we have 6 of our fellows, 6 of our 9 young doctors that are training to be oncologists here. So as fellows, we'd come out almost feeling a little depressed. We expected more at this meeting. And then John and Mark would pick us up that it's really the research, it's the clinical trials, and really drilled a lot of basics and fundamentals. And a lot of us that trained at Pittsburgh continued to go on and work in kidney cancer, melanoma. And when we get to, when we're at ASCO meeting in Chicago, all of us tend to gravitate to the same meeting. Actually, we were all in Chicago a couple of years ago together, the Pittsburgh group. So it's really an honor that Mark drove up from Bethesda, where he's really serving the whole United States as the immuno-oncology branch chief at the National Cancer Institute. We have, we're going to go through, I just want to give you a high level. Dr. Ballou is our head of nephrology, and he's been very, very helpful in making sure our kidney cancer survivors' kidney function is preserved and saved so that and he's done a really good job. And then, the Durr family and the foundation have had such an impact on my career, on our life. And Andy is somebody that inspires us on a daily basis. I met Andy actually through his daughter Megan, who started in oncology on 7C, which was our inpatient floor. And then Megan, joined us in clinical trials. She was when we joined Memorial Sloan Kettering about 8 years ago. She was our first MSK quality nurse, and she also, I think, kept me out of trouble by editing my slides when I had to make presentations to MSK boards. So she's had a big effect. But through her, I met Andy, who's just amazing family man, man of the people, engineer, brilliant. He was a businessman, but really Andy was all about life and loving life. And Andy's kidney cancer came back at year 11, and he was very involved in clinical trials. He went on a clinical trial here. He was the first to get nivolumab and brought a lot of things here to the Lehigh Valley that's helped a lot of the survivors that are here, some that have attained cure, some that have had lives expanded, and then his family's continued his legacy and honoring his wishes in building this. And so we're all together for, it's community, it's really amazing. So one of the things in kidney cancer is that we know that we need more and more research. We knew even back in the 80s we could cure a small percentage of advanced kidney cancer with immunotherapy. Now we have treatments, and we're increasing that percentage more and more each year. And now we're getting to a groundswell of more and more positive things. And we're kind of balanced because at the same time that we're doing this, we know we're not there yet. We need more. We need more breakthroughs. We need more help. And research is the key. So I'd like to introduce my mentor, Dr. Mark Ernstoff.
Thank you, Suresh. I think your community is blessed to having someone so skilled and compassionate as Dr. Nair. And it was actually my pleasure to have him as a fellow. I probably learned more from him than he did from me. So with that, why don't we move forward? I'd like to tell you a story today about immunotherapy. It's optimism and hope as we go forward. But it has a long-standing historical foundation, and I want to give you that to take home today. So back before the Common Era, Parmenides in Greece said, "Give me the power to induce fever and I cure disease." Fever is a hallmark of inflammation. It's a hallmark of the immune system. And so way back then, there was a recognition that the body was the best physician. So we're going to go back first 283 years, and we'll go back then 132 years to tell you this story. So in 1740, there was a start of the War of the Austrian Succession, and that had importance to research because back then the Austrian, Charles VI, the Holy Roman Empire, the ruler of Austria, had died. His eldest daughter, Maria Theresa, assumed the throne, and Europe didn't like that, a woman assuming the throne. And so they went to war. At that time, a young surgeon in England by the name of James Lind joined a war vessel, 50-gun vessel, in Salzburg in 1740. And he noted as they traveled around the world that many sailors got sick. In fact, 80 sailors out of 350 were afflicted with this disease that had fungus, fleshy, putrid grums, and most dreadful terrors, in other words, scurvy. And they didn't know what to do with scurvy. At the time, the British Navy treated scurvy with elixir of vitriol, a dilute solution of sulfuric acid. They bloodletted patients. They applied pieces of turf to the patient's mouth because they had no idea what the mechanism, what the cause of this was. And so what did Dr. Lind do? He did the first randomized clinical trial. He took 12 men suffering from scurvy. He divided them into 6 pairs and then treated them each with different therapies. He randomly assigned a group to a quart of cider, or a couple of drops of elixir of vitriol, or a pint of seawater. But some of them got 2 oranges and 1 lemon a day. And what he observed is at the end of the week, the patients, the sailors getting the citrus fruits, were well enough to nurse the others. And so he did a systemic review of the written literature at the time, didn't find much, but eventually published years later, and it took the British government 42 years to institute this therapy after it was proven. So we've come a long way from them, but this was the foundation of randomized clinical trials and the importance of doing those. We now move to 1891, New York City. A very young surgeon by the name of William Cooley made an observation. He was treating patients with bone disease, bone cancers, and he observed that Ms. Dashel, a 17-year-old girl, had died very quickly after her bone cancer was removed from metastatic disease. And yet there was a Mr. Stein, a German immigrant, who was found alive and well 7 years after his tumor was infected with erysipelas, a bacterial infection. And so what did he do? So this is for the fellows. He did a literature search, because that's what you do first. And the literature search did find a number of references where people that developed infections in their cancers had curative results. And so he did a phase 1 study. It's a classic phase 1 study. Treats 3 patients, you don't see any problem, you add another 3 patients. So he treated 3 patients. And the 3 patients he infected with bacteria, and the 3 patients had response to their tumor, but 2 died from infection. Not good. So that was the maximum tolerated dose, and he had to go back and rethink. So he rethought what was going on. So he decided he heat killed the bacteria. So he heat killed strep and serratia, and that was born Cooley's toxin, which many of us consider the foundation of modern immunotherapy today. He published that back in 1914. So this is Dr. Cooley. Unfortunately, Dr. Cooley passed away from acromegaly later on, and he was challenged at the time. So this is the politics of medicine. He was challenged at that time by this gentleman on the front of Time magazine, who was James Ewing, the pathologist at Memorial Sloan Kettering, who described Ewing's sarcoma, who was enamored with radiation therapy and decided to discredit Dr. Cooley's work. And so for years following Dr. Cooley's death, his daughter worked very hard to reestablish his reputation. So cancer and immunology is well established over the years. This is a busy slide, but it goes back to 1908 with Paul Ehrlich with the immune system, the magic bullet. And many of these individuals received Nobel Prizes for the work that they did. And the ones that I would point out that are on this list, that not necessarily won Nobel Prizes, but made major contributions, is a guy by the name of Richard Gershon, who was at Yale when I trained, unfortunately passed away during my fellowship, who first described what was called regulatory T cells. And they fell out of favor. No one could find them. And so for years, no one believed them. But it wasn't until 1995 that Sakaguchi discovered that they did exist. And a lot of our therapies now focus on regulatory T cells. The most recent Nobel Prizes were given to Hanjo and Allison for their discovery of immune checkpoint inhibitors, and we'll describe some of that. We had described back in 2000, based on some of our immunotherapy studies, that the host, your body, was already primed in some way to respond to immunotherapies, and that's what we're beginning to find today. And finally, I will describe to you some of the work by Robert Schreiber from Washington University Washington University? WashU in St. Louis, what is now considered immune editing, which is the way your body responds to cancer. So immunology is important. This is my daughter's 8-year-old view of immunology in 1994. She took her homework home. I helped her. She failed that exam. It was a hard learned lesson for me. She inherited my gift for spelling. If you read below there, the white blood cell is eating the germ, spelled J-U-R-M. So some things don't fall too far. Kidney cancer has improved, and some of the big picture look, you can look at the SEER database, which is the surveillance of epidemiology and end results, which the NIH keeps. And kidney cancer, which has been rising in incidence, increasing about 0.6% every year in the United States. Nevertheless, the death rate is falling. The death rate is falling both in localized disease and in metastatic disease, suggesting that we are in fact making headway. Some of that headway is understanding biology, Some of that headway is real therapeutic interventions. So let's look at the story of immunotherapy for kidney cancer. And it really falls into a number of different baskets. So the first basket is the cytokine story. So cytokines are proteins, are molecules that communicate from one cell to another and are instrumental in controlling your immune system. And back in 1954, Nagano and Kojima published a study in French, so it didn't make it to the English literature. They identify that if you incubate cells with viruses, they produce a substance that inhibits the virus. Independently, in 1957, Isaacs and Lindemann described the same phenomena, and because it interfered with viral reproduction, they termed it interferon. And it made a big splash. In 1960, it hit the comics. So this is a Flash Gordon comic. Flash's man is infected with a space virus. This is a phase 1 unit in space. We'll probably get there at some point. And lo and behold, he gets interferon, and the virus goes away, and the fever comes down. And for those of you that have used cytokines, the fever goes up. Nevertheless, this is an N of 1. But it means that you guys, the community, the public, is very interested in immunotherapy and immunotherapy for cancer. So this is the 1908 New York Times article on erysipelas curing cancer from Coley. Interferon made the head of 1980 in Time magazine. In 2013, on the cover of Science, one of the most prestigious journals, that cancer immunotherapy has arisen. But it's expensive. And so in Time, in 2016, identified the cost of a lot of these therapies. Nevertheless, Lehigh Press is full of both books and websites that are focused on immunotherapy of cancer. But the beginning of the modern era of immunotherapy for cancer was not pharma. It actually was developed by these two people on either end, Matilda Krim, which was head of the HIV and the interferon studies at Memorial Sloan Kettering, and Jordan Gutterman, who was a physician at the MD Anderson. Matilda Krim was very friendly with Mary Lasker, the Lasker Award, the Lasker Foundation, got them to commit $1 million. They then negotiated with the American Cancer Society, a private foundation, to raise $2 million. The NIH kicked in $1 million, so this was a collaboration. No pharma here. So the efforts of your foundation are really important for the help in developing new therapies for cancer. And the cytokine era demonstrated that there was a benefit in patients with metastatic kidney cancer. The first paper by Dr. Gutterman's group back in 1983 demonstrated that there were patients that had metastatic disease that had response to interferon alpha. This interferon was produced by the Finnish Red Cross, came in big buckets, because we did not have protein synthesis. We did not have recombinant DNA technology. This was before 1980. And so we did a study when I was at Yale of looking at higher and lower doses of interferon to determine whether this was a dose response. And we found 7 responders in these 30 patients. Hymus, who's a colleague, summarized the data demonstrating that across all different kinds of interferons there were benefit. And in fact, there was a study looking at, in the metastatic setting, removing the kidney or not removing the kidney, and then giving interferon, where removing the primary in the setting of metastatic disease was important. We term that today abscopal effect, meaning an effect distant to whatever you're doing. Many times it was described in radiation therapy, but there was an abscopal effect. But it tells us that there was something happening in the primary, probably because they were large, and probably producing some very important immunoinhibitory molecules like TGF-beta that could affect the body's response to immunotherapy. The cytokine era was then enhanced by the discovery of a T-cell growth factor. T-cells are important as cytotoxic cells that target your cancer. And the T-cell growth factor was a cytokine that was termed interleukin-2. Steve Rosenberg and his group at NCI was primarily involved with the development of this. They took cells out and grew them up. He called them lymphokine activators. killer cells. They turn out to be what are now termed natural killer cells, and Dr. Nair and I worked with the discoverer of natural killer cells, Dr. Herbermann, when we were both at the University of Pittsburgh. And so there was evidence that, that these cells, this cytokine, enhance potential benefit for patients with kidney cancer. The original group to establish the findings from the NCI was called the Cytokine Working Group. It was later expanded to include a number of other of us that were involved, and we stayed together for many decades, even after funding disappeared. Some of the work at NCI was supported by Dr. Armand Hammer from Occidental Petroleum, again, private investment in our efforts. And what was found with IL-2, as Dr. Nair had mentioned, is that there is a small subset of patients that go into complete remission. And if they go into complete remission, that top curve are the complete remitters. They have a long-standing, potentially curative course. So it told us that there was a crack in the door, that the immune system could in fact cure patients with cancer. Not many, but some. So there was a mechanism by which that had to occur. So we took that a step further. We said, well, the immune system is pretty complicated, and you have to recapitulate it. So you have to give an antigen. So we, when I was at Dartmouth, developed a dendritic cell vaccine. Dendritic cells were discovered by Dr. Steinman, who ultimately won a Nobel Prize for that after he passed away, the only person to win a Nobel Prize after death. And dendritic cells are important. Dendritic cells take stuff, usually proteins, process them, and then touch the T cell. They have to actually physically touch, and they educate the T cell to attack that target. So that was an important thing. So we took patients, we took their tumors, we crushed them up, we lysed them, we fed them to their own dendritic cells that we took from their blood. We then gave them back in the location where they could touch the T cell. So we actually injected them right into the lymph nodes. We did that using ultrasound. But the T cells that were being developed needed a growth factor. So we gave IL-2 with this vaccine. When the T cell sees the antigen, it sees it in the context of what's called MHC class 1 molecules. Everyone in this room has a whole bunch of MHC class 1 molecules. Many of us share the same. Many of us have other ones. It's that molecule where your proteins are processed. That's like a mitt, and the protein segment is put into that mitt, and it's that ball and mitt that your T cell sees. It sees it through the T cell receptor, and that T cell receptor we're going to talk about at the end of this disease. So to upregulate that MHC molecule and to upregulate the tumor antigens, we gave interferon alpha. So this study was 18 patients, and you can see the survival curve here. We had 3 objective responses, 3 complete responses, and they continue to do well even to this day. And we looked at their immune system. The immune system in patients with metastatic cancer are inflamed. If you look at their signals in their blood, they have an ongoing inflammation. And after these patients went into complete remission, that inflammation began to go back to what was considered normal. So this is important observations in these things. And to understand how that immune system works, Dr. Melman and Dr. Chen had proposed what is called the immune checkpoint control and the immune cycle, where you can see, I don't know whether this pointer is there, that antigens or proteins and other molecules from the tumor traffic into the lymph node, are gobbled up by your dendritic cells. The dendritic cells, as I said, touch your T cells. This area where that happens is modulated primarily by a molecule called CTLA-4. And CTLA-4 is a downregulator. These T cells then have to get out of the lymph node, traffic back to the tumor, get into the tumor, and kill the tumor. And in this tumor microenvironment is where your PD-L1 molecule is primarily involved with. So these molecules are influencing your immune system at different physical locations as you go forward. And so there's this concept that your immune system actually surveils you and can eliminate tumors. And this is the work from Dr. Schreiber, built on the shoulders of giants again, as we say, from Ehrlich and Burnett and Thomas, that demonstrated that we're constantly forming malignancies in our body. Your immune system recognizes them as foreign and eliminates them. But in some cases, the tumor takes root. But the immune system controls it, and it can control it for a small amount of time, or it can control it for a long period of time. But ultimately, the tumor is going to evolve, and it escapes. And when it escapes, you develop cancer, and you develop metastases. And as cancer doctors, that's what we see. We don't see all the stuff going on beforehand, though there's a lot of work in immunotherapy trying to establish therapies of pre-malignant lesions as we go forward. So in 2018, as I mentioned, Hanjo and Allison won Nobel Prizes for the identification of these what are called immune checkpoints. So these are areas of regulation that tell your immune system to stop. So each of us, when we're born, have T cells that see a lot of us, and there is a process by which those T cells are eliminated from your body in your thymus gland. That occurs early so that you don't have autoimmunity, but some of them escape, some of them do live, and they're controlled, as we are in health, through these checkpoint inhibitors, these checkpoints. And so we've developed checkpoint inhibitors. These are antibodies that target these molecules. The antibodies were developed by a small company that I happen to be involved with called Medarex at Dartmouth. The names were MDX-010 and MDX-1106, ultimately purchased by Bristol Myers Squibb and developed as ipilimumab and nivolumab agents that we know today. So how do these work? So this is a cartoon of establishing where these molecules function. So you have an inactive T cell. There's a dendritic cell, and as it presents the antigen for the T cell to be activated, it needs a second signal to get activated. That second signal is what's called CD28, which is over here, and that has to engage for the T cell to be activated. But it's competitively inhibited by this molecule called CTLA4. So if you block this synapse, you block this junction with this antibody, you can allow the CD28 to engage with its other ligands, which is CD80 and 86, and allow the T cell to become activated. And in fact, the initial studies demonstrated that this, in fact, does happen, and it does affect patients' outcomes. PD-1 and the PD-L1 axis is also involved with this. So your T cells have a receptor called PD-1. That receptor is upregulated as the T cell gets active, because you don't want your T cells to go crazy. You don't want them to be active all the time. So they have a self-regulatory process where they say, let's turn off. Let's become exhausted. Let's go to sleep. Okay? And that's a natural process. And what happens is that this T cell, it's a very tricky computer here. This T cell produces a molecule called interferon gamma, very important in its function. But interferon gamma upregulates on the target the ligand, PD-L1. And it's the PD-L1 that then blocks the activity of the T cell. So again, developing an antibody that blocks that intersection can reinvigorate your T cells. So we're now in the era of immune checkpoint inhibitors. In the background, which I haven't described to you, is a whole bunch of other studies going on to target what's called vascular endothelial growth factor. So the original studies that were done in inheritable kidney cancer by Dr. Linehan at the NIH identified a factor which is called vascular endothelial growth factor, which is critical in the development of kidney cancer. And since it is critical and is regulated, you can develop molecules to block it. So some molecules are antibodies, like Avastin. Some molecules are small molecules because this target has a whole enzyme profile that is in the cell. And those are the inhibs, sunitinib, pazopanib, and all the other IBs that target VEGF. And so in the background, VEGF became a mainstay of therapy for kidney cancer. And those of us in the immune world said, oh boy, we got challenges here on how to move this forward. Nevertheless, when the immune checkpoints came along, it was clear that they had a role in kidney cancer. And we then recognized that VEGF not only controlled kidney cancer, it was also involved with immune regulation. And so naturally combining these agents made perfect sense. So now going forward, as you know, and many of you may have been involved with some of these therapies as clinical trials, we now have a number of agents that are immune checkpoints alone, immune checkpoints combined, immune checkpoints with VEGF inhibitors that are standard care for patients with metastatic kidney cancer or patients at risk for developing metastatic disease that get it in the adjuvant setting. And so these are some of those studies that have been developed. I don't need to go into each of them, but clearly major breakthroughs in developing strategies for kidney cancer. And these are just some of the survival curves. This is in second-line therapy, showing nivolumab was in better than everolimus, which is called an mTOR inhibitor. It's a little different, but nevertheless better than second-line therapy. These are studies for both intermediate grade and poor risk patients, demonstrating that immune checkpoint inhibitors were significantly better than the TKIs, and again, similarly in this situation. So now we're in the immune checkpoint inhibitors. But as Dr. Nair mentioned to you guys, we're not there. We still have a lot of work to do. And so where are we going today? So where is the research taking us? So we now have the ability to modify our genes. You know, we can do this through any number of ways, but all of a sudden we can now take your immune cells and change them genetically, and then give them back to you. So we can do that by giving you back adoptive cellular therapies. We now know a lot of the targets, both on the immune cell and on the cancer cell. So we can develop engagers, what are called BiTEs, bispecific T-cell engagers. There are TRiTEs, tri-specific, and there will be more as they develop to bring the T-cell to the cancer and activate it. There are numerous and many other cytokines and chemokines. Chemokines are what attracts the T cells, lets them move around your body. So there are many of those that are now being developed and need to be given combined. PD-L1, PD-1, CTLA-4 are just one of literally dozens of molecules that interact with your T cell. Each of those checkpoints are strategies for therapy. And we need better prognostic and predictive biomarkers as we go forward. So what are we finding? And we are able to use artificial intelligence to help us with this, not ChatGPT, but some other approaches, to help us understand what the signals are, what the motifs are, to further understand the biology and the pathways of why tumors metastasize and kill us, what are the targets, what are the pathways, and then how do we manage the toxicity? So you're going to hear about how to manage the single kidney. Managing toxicities of both surgical and other therapies are really important. And finally, how do we manage survivorship as patients are living longer? So this is a cartoon of the synapse between your T cell and your antigen presenting cell, and that synapse has all these molecules that control the interaction. Each of those molecules are targets, either targets to agonize with, stimulate, or targets to inhibit. And each of these are being developed as we go through the research in this area. What about the genetically modified cells? So on the left-hand side is the construct of the CAR T cells. CAR stands for chimeric antigen receptor. So these are novel receptors not seen in nature that are designed by pretty bright people. They have to design the part of the antibody that sees the antigen. The antigen has to be expressed on the cell surface for this to work. Okay, that's an important, as we got into the other side of this cartoon. So it sees a cell surface marker. It then has to signal for this T cell to get activated. And there's a lot of different ways of doing that. And how is this done? You take the blood out of a patient. So for many of it, it's autologous. It's a long process. A lot of people are looking at allogeneic, some off-the-shelf T cells that you can use. But you take them, you then expand them, and as they're expanding, they're doubling and growing, you can integrate into their genome a specific tool. The tool is the CAR T cell. You then expand them. You then get them ready to get back to patients. You need to make room for those cells. You need to let them engraft. So there's a process called lymphodepletion, giving high-dose chemotherapy to get rid of all your immune cells, to allow those cells to engraft, and then bango, something happens. This has been remarkably effective in B-cell lymphomas, B-cell malignancies, okay? Big change in that therapeutic area. Exceedingly hard in solid tumors. We're still a long way in developing that. So we take a different approach, what are called TCRs, T-cell receptors, okay? The T-cell receptor, as I mentioned to you, sees that bit of antigen, that bit of protein in the HLA. So all your proteins, even your intracellular, the proteins hidden in the cell, can now be expressed by this and seen by your TCR. So we're now developing novel TCRs that we transfect into the T cells and give those back. We're developing armored T cells that can figure out how to evade the immune suppression effects within the tumor microenvironment. There are a lot of ways of doing that. It's a very, very exciting area of research. And we have, the NCI has just stood up a network to begin to further research this area of adoptive cell therapy for solid tumors. What about BiTEs, trites, and other engagers? So those are antibodies. One part of the antibody sees your T cell. The other part of the antibody sees your tumor cell. And since they're combined, they bring the T cell into your tumor cell and activate it. So those are trites and BiTEs, and some of those have been approved, and some of those are moving forward. So this is a way to use your own immune cells. And as I mentioned to you, the tumor microenvironment, which is, you'll see in the next slide, is what I call the room where it happened. For those of you who've seen Hamilton, it's in the tumor microenvironment. And the tumor microenvironment is awash in both stimulatory and inhibitory processes, and they're provided for you here. I don't have to go into all of them. Some of them are cells. Some of them are those proteins, the communicating proteins called cytokines. Some of those are these checkpoints and other things that are really critical in modifying that. So how do I look at it? This is the room where it happens. Immunotherapy is the only therapy that uses living therapy. We're using your T cells. We're not treating your cancer. We're treating your T cells or your NK cells or your cells that kill the cancer. So we can do that by giving the cytokines and chemokines. We could do it by giving certain drugs. We can modify the cells as I just described to you. We can give antibodies, we can give small molecules, and we can give engineered antibodies, but they're all designed to stimulate this guy, the effector cell. And it's the effector cell that gets into your body that then kills your cancer. We got to get rid of the cells that prevent these effector cells from working. Those are called regulatory cells. Dr. Nair and I were just discussing, there are regulatory cells that are called myeloid-derived suppressor cells. That is relatively new, probably critical in kidney cancer. We now have therapeutics that can modify that environment, so we have potential new therapies that are moving forward. And the tumor microenvironment is got a lot of other things going on in it. It's got blood vessels. It's got tumor-associated fibroblasts that form the structure around it. It's got soluble factors that mediate through that. Each of your cells make these little vesicles called exosomes. And these little exosomes have packages of stuff in them that communicate between cells. And it turns out that your tumors have nerves in them. And there is a whole area of neuroimmunotherapy that is evolving. And finally, there's the extracellular matrix, the stuff that the collagen that we all want to get rid of as we age. that collagen, there are many different forms of collagen. They're stimulatory and inhibitory, but they form the foundation of that tumor microenvironment. So how do I look at it? Simply, we got to get inflammation back many, many thousands of years ago. Inflammation is important. Got to get rid of the regulatory cells. Got to get these T cells and other cells to traffic into the tumor. Got to get rid of the tumor evading processes, and then that will ultimately destroy your cancer. So there is a lot of hope, and I'm always left with observation that a very well-regarded evolutionist by the name of Stephen Jay Gould, who passed away, was a Harvard a professor who was noted to say that he had developed a very aggressive form of cancer called an abdominal mesothelioma, and was slated to die. And so he pulled up Mark Twain and said, "The reports of my death are generally exaggerated." And he wrote a little essay called "The Median Isn't the Message." And it struck me as something really important. So in July of 1982, he learned that he was suffering from this rare disease. He received surgery, and he asked his first chemotherapist, "What about the literature?" And she replied, "Don't be silly, don't go to the library, don't read anything, because everyone basically dies." But not everybody dies. And so he did his own literature search, and he realized that while it's, quote, incurable, the median mortality was only 8 months, but that's the median. And there is a curve. So the median mortality is the median. It probably means that many patients, half of them, will die at that median time point, but the other half is going to live longer. And there is a tail on the curve. And he held tight to that tail on the curve. He actually participated, he didn't say this in his essay, in a research study, high-dose chemotherapy and bone marrow transplant. Don't use that anymore. Didn't work. It worked in him. He was the tail of the curve. And so he observed that biology is about variation, and that's the hard reality. And secondly, that even with the knowledge of prognostic features, it is often difficult at diagnosis to know whether a patient will or will not be on the right or the left-hand side of that curve. And so we all hope that our patients are all on the tail of the curve, and fortunately you in the room are. And I wish you all well, and I thank you for listening to me. And I just leave you, probably all of you in this room are well aware that the most important things in our lives are our families. This is my family as we visited the Galapagos. So, thank you.
Thank you, Mark. Yeah, that was wonderful, Mark. And when I listen to Mark, it brings back memories from 35 years ago, and he always gets our brain thinking. I never realized scurvy was the first clinical trial, and that it took the government 40 years to prove what actually worked. And I think what Mark ended with is really important for our survivor group. I'm fortunate to take care of about over 50 patients that have stage 4 kidney cancer, and many more with stage 3, stage 2. And with the stage 4, we were seeing tail in the curves back in the 80s and 90s. With interferon, then with interleukin-2, thanks to Mark and others training there. When I first moved here, 2004 to 2017, we had a high-dose interleukin-2 unit. Megan was one of our IL-2 nurses. And we were able to treat 90 patients. 50 of them had metastatic melanoma, and we cured about 5 metastatic melanoma. And about 40 had metastatic kidney cancer. We were a referral site from Philadelphia, Fox Chase and Penn sent patients here, and Geisinger, where I had been. And in kidney cancer, we actually, just with interleukin-2 and possibly some surgery removing a single spot, we cured 6 out of our 40. But then what was really amazing with kidney cancer was that some of our patients were partial responders, where they were in remission a couple of years. Then all of a sudden, the next rendition of medications came out, like ipilimumab, nivolumab, and some of the patients then got secondary long-lasting remissions that we hope will be cures. So actually about 15 out of our 50 patients are doing well now, 7-10 years out. And I don't know if I saw Jim. Are you out in the audience, Jim Evans? Yeah, Jim, can you just stand up? So Jim is someone that actually participated in interleukin-2 back in 2017, and Jim's given me permission. He actually, Brittany Sweeney from PBS in the Lehigh Valley wanted to be here, but she had a conflict, so she interviewed me and she interviewed Jim. And thank you, Jim, for talking to her over the phone. About 7 years ago, Jim, I'm just guessing from my memory, you were about 51, 52. Jim's a chef from near Scranton, Covington Township. He, out of the blue, had an x-ray that showed 50 spots in his lungs and had a kidney cancer. And he saw a close friend of mine, trained at the same era, Naomi Haas. Naomi was coming out of Ohio and came to Fox Chase same time I was coming out of Pittsburgh. We've been friends ever since, and she was a big supporter of our IL-2 program. And then she's now head of kidney cancer research at University of Pennsylvania. In fact, Andy saw Naomi Haas, and so Jim was seeing Naomi in Philly for looking at clinical trials in 2017 and 2016, and so some of the new things were still developing, and she said, I think you can try high-dose interleukin-2 because it's something that does have that tail in the curve, maybe 10% maybe cured, but and so it wasn't easy. But Jim, 2017 was our last year for doing interleukin-2 because we started getting these other treatments. It was a grueling treatment inpatient. We treated 90 patients, probably about 400 admissions, thanks to the amazing nurse Melissa's here, who helped run the program. We were able to get everybody treated safely. Only a couple of our patients were in the ICU, but Jim, many of the spots faded. And then that got him into the clinical trial, which we were part of a trial called BMS Fraction. It was a Bristol Myers trial with ipilimumab and nivolumab, and that worked. And then another medicine, cabozantinib, came out. So Jim was able to, at the start of COVID, he had been in remission. We took him off the cabo for a brief period, and right at the start of COVID, he came in to Cedar Crest ER with shortness of breath, and for all the world it looked like COVID, but it wasn't. It was actually some reflare because of the blood supply. So the next day, Jim's wife was smart enough to bring in the cabo pills, and so we called the floor. I don't even know if I don't think you were in the ICU, but you're on oxygen. We said, what he really needs is to go back on the medicine, which he did, and within a week, the spots started clearing up, and he's been good ever since. And so it really shows, what Mark was talking about, optimism and hope in the modern era. And I think when I, look around all the tables, I wish I could, it's like a wedding reception, I wish I could spend half an hour at each table, but it's many unique stories, but we're all getting there, different ways. And I think, Mark, it was a very complex and thought-provoking talk in a very understanding way. So thank you for being here, and thank you for helping us. Now I'd like to introduce my colleague, Dr. Ravinder Balloo. Dr. Balloo's head of nephrology for Lehigh Valley Health Network. He's taken care of many of you, and he's really going to talk about keeping our kidney healthy, even if it's a single kidney. Thank you.
Hands down, that was one of the best talks I listened to on the history of immunology. I live in the world of immunology also. I'll let you know in a minute where I live in, why I got involved in immunology. Good evening. I've been at the network for 24 years, and I live in the world of single kidney. either people who lost the kidney due to malignancy, or people who acquired the kidney through transplant. That's what I do. So, this evening I would like to have one goal, to talk to you in simple English. After that lecture, I think you deserve a simple English. Okay, thank you, Mark, making my life easy. My idea is to talk to people, folks and their loved ones with a single kidney, how to preserve the function and prolong the life of the kidney. Okay? Without much ado, I will start from there. So I'll start with the basic anatomy. Again, I'm talking to you as if you don't know anything about medicine. Okay? Forgive me if you know. My idea is to talk to you in simple English. This is what I do with my patient. So I'm talking to you as if you are. So all of us here are born with two kidneys. Very rarely, like 0.1% of the population are born with one kidney, one functioning kidney. The kidneys are in the abdomen, close to the back. And these kidneys have a lot of reserve. Each kidney has about 1 million filters, these tiny filters. And that's why there's a lot of reserve when we're born. These filters does remove excess water, toxins, and also guides the bone marrow to generate red blood cells and helps the bone health by being part of vitamin D making process. So when portion of the kidney or one kidney is removed, that means you are losing part of that reserve, the filters. What happens is rest of the kidney, what is left, will try to pick up the slack by what we call it as a hypertrophy or enlarging in the size of the kidney. When I say enlargement, what happens is the size doesn't increase by adding more filters. Whatever filters we are left with, those grow in size and handle the rest of the system. It is not a perfect adaptation, but that is good enough for one kidney or part of the filters, like out of 2 million filters, 1 million filter is left over, that is good enough to get through rest of the life without any problem. Size is one thing, but the function is second thing. What happens is the kidneys increase in size and the function will almost get to 70–80% of the kidney function before the removal of the kidney. It happens more so in young folks compared to older. That's one reason we don't take kidneys as a donor after 65 years, because the adaptation will be low after 65 years. So when you take the reserve and you throw some more stress on top of that, which I will get to in a minute, so that will create a situation for us to condition called chronic kidney disease. Okay? When I say chronic kidney disease, this is the definition. Presence of protein in the urine, excess amount of protein in the urine. All of us will drop some protein in the urine, up to 1/4 of a gram. Anything more than that is considered to having leakage in the leakage of protein. And second thing is changes in the anatomy or the at the microscopic level in the kidney. The kidney function number could be good, but the changes happening in the kidney microscopically and presence of protein in the urine for more than 3 months is considered to be technically a chronic kidney disease. Based on the studies, what we know, after kidney is removed or part of the kidney is removed, chance of developing kidney disease is there, chronic kidney disease is there. The incidence is about 20% with full kidney removal and 10% or so in the partial kidney removal. So when kidneys reserve is taken out, people develop chronic kidney disease. Also at the same time, people who has chronic kidney disease to start with, say from multiple factors, which I will get to in a minute, those people also at high risk for developing kidney cancer. say somebody who's on dialysis for a few years, 3 years, 3.5 years, the chance of kidney cancer is there for them to develop. And most of the people with chronic kidney disease, or when they have cancer, might have chronic kidney disease to start with, based on other comorbid conditions they had before the cancer development. Based on the recent studies, the early stage cancer identification is getting better and better. So are the treatment choices. If you find them early, instead of removing the entire kidney, the technology is allowing us to get to partial nephrectomy. Partial is better than complete loss. Also, another factor that adds to the burden for the leftover kidney is development of acute injury at the time of surgery. So when people get partial or complete nephrectomy, depends on the age, depends on the male versus female, and depends on the body size or body mass index and underlying kidney disease, the chance of development of acute kidney injury is there at the time of surgery. If people develop acute kidney injury, their chance of developing chronic kidney disease few months later is much higher. So we take all the precautions as best as we can, given the situation. We try to optimize the patient before the patient goes for surgery to prevent this acute kidney injury, acute event. As I said, the stress factors. The people who has chronic diabetes mellitus, high blood pressure, chronic smoking, and prior kidney disease. Most of the kidney disease in the world is from diabetes mellitus and hypertension. And there are other multitude of reasons why people develop chronic kidney disease. Okay, and one of the conditions called glomerular disease. And as Dr. Mark said about some of the medications that are in development or in use, vascular growth factors, VEGF they call, they can cause side effects, adverse effects. And they can increase the blood pressure, and they can also makes these filters in the kidney to spill the protein. Protein spilling to a certain extent is okay, the kidney can survive, but crossing certain number, more than, I said 1/4 of a gram is normal, say 2, 3, 4, 5 grams. Kidney is not, the filters are not used to don't know how to handle the protein. They eventually cause what we call it as a scar tissue or fibrosis inside the kidney that leads to lower kidney function. We also know people who has chronic kidney disease are at a higher risk to develop cardiovascular disease. So high rates of chronic kidney disease can lead to cardiovascular mortality and morbidity. As I mentioned before, idea is to preserve as much kidney as possible if somebody has to undergo surgery in the setting of cancer. People, because of advanced surgical technologies, they're able to preserve the kidney, even the kidney tumor size up to 7 centimeters. It used to be like 4, now they're able to go to 4 to 8 centimeter kidney mass. They're still able to get away with the partial nephrectomy, again, to preserve as much kidney as possible so that you will not develop chronic kidney disease, which has its own problems. Putting all things together, this way it works. When you reduce the number of filters, the existing filters grow in size. And now the reserve is limited, you should not try to add any stresses to the leftover kidney. And the stress factors are to the kidney: high blood pressure, diabetes mellitus, high body mass index or obesity, smoking, and pre-existing chronic kidney disease, which you can't prevent by the time somebody develops cancer, or main thing we can do in the hospital during the setting of surgery is to prevent that acute insult to the rest of the kidney during surgery. And then if all these factors are there, this lead to chronic kidney disease. And as I said, one thing you can do, be part of your own care, how to prolong the life of the kidney. As I always tell my patients, you are the quarterback. I'm here to help. I'm the coach. I can put myself in the coach role, but I am not the player. I'm not the one who's playing, right? So this is what we monitor in the setting of chronic kidney disease: blood pressure, blood glucose, lipid panel, blood work. That blood work, when you see the report on in your lab slips, you will see the electrolytes and something called creatinine. Creatinine is the one that kidney try to eliminate. That's a waste product coming out of the muscle. It will be eliminated through the kidney. The lower the number is better. If the number is higher, means kidney is not able to get rid of it. The amount of creatinine depends on your muscle mass, okay? And you see the small fluctuation as you follow your lab data. And we also do urine studies. When we ask for urine analysis or urine studies, what we're looking for is protein level in the urine. So that tells you the kidney damage. Higher the protein level in the urine means it's a kidney damage. In a simple analogy, imagine the kidney like a coffee filter. Okay? Water and coffee is equal to blood. And the filter is the kidney. And the coffee in the pot is the urine. And the grounds in the coffee is the protein. If you're seeing coffee powder in the coffee pot, that means the filter is leaky. As simple as that. Okay? But with the advance of science, we are trying to help to prolong the life of the kidney. There are a lot of blood pressure medications that to get to the optimal number. But there are certain classes of medication that is important to help to prolong the life of the kidney. One class of medication is called ACE inhibitors, or ARB, number one. For the blood pressure control, that's the right choice of medication to help to prolong the life of the kidney, either diabetes or small kidney or small amount of the kidney. Number two, for diabetes, there is a new class of medication called SGLT2 inhibitors. Okay? And there is a newer class of blood pressure medications are coming up. There's something called MRAs. So controlling the blood pressure, controlling the diabetes are the two key important elements that you can help with. The next question is what you can do, what a person with a single kidney can do. Can you change the diet? There is not much data out there. Controlled clinical trials are not there to tell what to eat, what not to eat. Say, what we know is higher the amount of protein, higher the stress to the kidney. As I told you, I'm going to talk to you as if you don't know anything about medicine. So what is the right amount of protein? Normally, for healthy people with normal kidney function, 1.5 grams to 2 grams of protein is a normal amount. So amount of protein about 1 gram per kilogram. Otherwise, you get into malnutrition. Try not to limit your protein to too low. And the sodium, salt intake. Try to do your best to minimize it. And sugar control. We monitor something called hemoglobin A1C. It has to be between 6 to 7. That's the goal. Blood pressure, 128 is the right number. Stop smoking. And medications. These are very common things people do. Back pain, go and get Motrin. Back pain, go and get Advil. do not take anything over-the-counter medications, particularly for the pain relievers. And other things, don't listen to the television commentaries about any herbal therapies. Nobody knows what they are. Okay? I will stop there. I said, I'm talking to you as if you don't know anything about medicine. This is why I talk to my patients to understand. No medical lingo, just a simple, straightforward talk. How to help yourself or your loved ones with a single kidney and prolong the life of it. As I said, I live in the single kidney world, either transplant or people with one kidney for other reasons. Okay, and I wish you all the best, and I'll be happy to answer any questions, simple, straightforward questions. Okay, thank you.
Any questions for Dr. Ballou in terms of kidney? The one of the gratifying things working with Dr. Ballou is he's so passionate. Even though he's an expert in dialysis, his goal is to not get our patients to dialysis. And I've been here at Lehigh Valley for 19 years. I've only had one kidney cancer patient of mine that's required dialysis, and that patient actually came here transferred from Atlanta from Emory. She had hypertension and the damage in the other kidney. It was shrunken, and then needed surgery for the diseased kidney. And I think that's quite a testament because taking care of probably 500 kidney cancer patients that have had single kidney or partial nephrectomies, the fact that he's taught me a lot. We're especially very careful about the iodine contrast and trying to minimize the use of that. If we absolutely need it, we use it with hydration, especially on some of the clinical trials. But he, I think, has saved so many kidneys, and I applaud your work, Dr. Ballou. It's the second time or third time he's given us this talk, so thank you.
But I have a wonderful team. I'm a part of a big team, and I have 20 guys with me, and I'm proud of my team. So anything we can do, let us know.
And I think our last speaker, almost no introduction. I think almost all of our survivors feel the love of the Andy Durr Foundation for Kidney Cancer, and I think it's very fitting for Megan to represent the foundation and talk to us about the mission. Thank you.
All right, thank you so much for coming out on this beautiful evening and spending your time with us. I'm Megan Barkanek, formerly known as Megan Durr, before I met my wonderful husband. I am Andy's daughter and one of the board members of the Andy Durr Foundation. So again, thank you so much. And we are honestly honored to be able to sponsor an event like this and meet and see all of you and provide this type of education. So I'm just going to share a little bit about how to be an advocate, which may sound like a huge undertaking, but hopefully by the end of my talk you realize that it could be something really small or something really big, but either way you're making a huge difference for everyone in this room and everyone suffering from kidney cancer. So just a little bit about who we are as the Andy Durr Foundation, right? So we were founded in 2016 based on Andy's dream of helping others through their own journeys with cancer. Over those years, so that's 7 years now, we have raised and donated over $380,000 to local cancer centers as well as support groups. Some you might be familiar with, like the cancer support community of the Greater Lehigh Valley. We focus on 3 pillars: research, education, and advocacy work. And it's really these 3 pillars that Andy focused on, which is why we chose them to continue to live his legacy. Research being one of his most important ones. He was a firm believer in innovation. He was an engineer by background, so anything research or science in general was of his interest. He believed in it so much he enrolled in a clinical trial and was part of these amazing immunotherapies that Dr. Ernstoff talked about today. Education, so he was really a firm believer in educating himself and others to the fullest extent and being able to partner with his physicians and care team, right, and really understand the treatment options and try to make the best decision. And then advocacy. He was an advocate. He was more of a formal advocate. He went to medical conferences to learn more about his disease and try to translate that into patient-friendly terms. Because as you can see, science has moved very quickly, and it's not always easy for us all to understand what the physicians are talking about. So why do you want to get involved? Why does this matter, right? So besides those of you that are possibly in your journey with cancer, a survivor, a family member, I don't even think I need the why slide for you. You get it, right? You're in the midst of it. You're trying to get through it. You're trying to be that support person. But I think there's sometimes a misconception in the public that kidney cancer is rare. Right? We see a lot of different advocacy groups out there for other types of cancers, and sometimes it feels like we're left in the dust. But actually, 81,000 new cases of kidney cancer will be diagnosed in the United States in 2023. It's the 7th most common cancer among men and women. That does change depending on what you look at. If it's the 7th or the 8th, it goes back and forth with bladder cancer. Even though there's only 81,000, which to me still sounds like a huge number, diagnosed each year, or this year, there's an estimated over 600,000 people living with kidney cancer in the United States. And that's a 2020 number, so that has probably increased since then. And in 2016, there were actually $0 specifically allocated in our national budget for kidney cancer research. Right, so as Dr. Ernstoff went through a lot of the various trials that have gone on, these do take a lot of funding and being able to do those. So ways to get involved, right? So you're like, Megan, I'm undergoing cancer treatment. I have a job. I have children. I am a grandparent. There's a lot of different things going on in my life. How will I ever be an advocate, right? You don't need to be standing on the steps of the Capitol building to be an advocate. There are many different ways that you can advocate for yourself. You can advocate and raise awareness for this disease. Right? You can be a volunteer, so shameless plug, you're more than welcome to volunteer for our foundation. You're also welcome to just volunteer at events, right? You can volunteer through different webinars, you can give 20 minutes of your time, you can give an hour of your time. To be honest, as someone that works in a philanthropy role on the side, time is sometimes harder to get than dollars, right? We live busy lives. The hospital also has something called the Patient and Family Advisory Council. Joanne, who's the president and was Andy's wife, is on that. I know Melissa Kratz is on that. I'm sure there's probably other people in the room that are part of that. But the goal of that is to be able to have your voice heard as a part of the Cancer Center, right? Helping to develop educational programs, helping to develop pamphlets that you receive in the waiting room, looking at different types of program development, building infrastructure. All of those types of things are some of the things that the Patient and Family Advisory Councils can be a part of. Again, you can volunteer at events. You're also welcome to be board members on various different advocacy boards. And one of the best ways that you can be an advocate for this disease is by enrolling in a clinical trial, if that is something that your provider and you feel like is the best option for you. So clinical trials are what help us to get answers, right? To move medicine, to be innovative. And you'll never get less than what is already standard on a clinical trial. So you will either get that and something else, more, right? Or at least the standard. So you're never getting less than what you would be getting anyway. You can be an advocate, right? So you can be more of a formal advocate, but I always say, be an advocate for yourself. Tell the physicians and your providers what you need. What are your goals, right? What are you feeling? You can be a formal advocate at things like conferences. So you can join through our big oncology conference is called ASCO. You can be advocates for a lot of different types of conferences where you go as a patient and you help to bring that information back in patient-friendly terms. Or you can be that formal legislative advocate if you so choose to do that, in helping to create more awareness in our legal system, right? And actually allocating funds for this. And then another great way to get involved, attending kidney cancer events. So right now, everyone in this room is, in my eyes, an advocate, because you're here and you're learning, right? And you're trying to make your survivorship the best it can be, or be that great support person for your family member. We try to spread a lot of our awareness and local events in the area. We spread word from the cancer support community as well, the hospital's events. So joining our mailing list, you'll be up to date on those types of things. Spread the word, right? And create awareness. So I called my talk Small Steps for Big Gains, because I'm not gonna lie, there are days that running a foundation feels like a lot of work and leaves me wondering, are we really making a difference? Is our little grassroots effort changing what's happening in the world, right? I feel like we're just this small little foundation, and I'm here to tell you that every dollar and every minute counts, right? So even though it's taken us, 6 years to get to some of these things, I look at these small steps and I realize the big gain and the big impact. So these are some of the things that our foundation has been able to help support. One of them being nurse navigation, which I am a huge proponent of. I'm a nurse by background. Nurse navigation for kidney cancer patients wasn't a thing when my dad underwent treatment, but because he was enrolled in that clinical trial, he had his own personal navigator named Morgan, who's hiding in the corner. I think many of you probably know her. And nurse navigation was something we were able to pilot to see how it worked and if it's worth adding into the FTE structure, right? And it did, right? It is now part of the system in total for these kidney cancer patients. Many of you know Angela, who I think is the original RCC, or kidney cancer nurse navigator. She's back there. And now we have the lovely Brigitte, who I have had the pleasure of getting to know over the last few months. And they're really your resource to be the person to help guide you through this very confusing thing that we call cancer care. We've also been able to help sponsor some different research studies that can directly impact you. One of them looks at what we call circulating tumor cells, and you're probably like, what is that? It basically draws your blood and looks to see if your tumor is releasing things in your blood that we can find earlier. So we really have to have cancer being at least a centimeter for a lot of our scans to be able to see it. The goal of this is to be able to see that a lot sooner, and to say that we can see your cancer coming back and treat it sooner, or at least watch how you're responding. I'm really proud of Dr. Nair because it got published in Nature, which is a huge journal. And so there's a picture of that publication there. And then impact testing, which is another type of research test done at Memorial Sloan Kettering, where we send your blood or your tumor to Memorial Sloan Kettering, and they look at it to see if you have what we call mutations. And what that basically is looking for is something that drives your tumor, or something that may be a gene that you have, whether it be a gene that you pass down to your kids, or a gene that's just in your tumor. But we try to find the match for if you have a treatment match that we can give you, like A plus B equals C type of thing. And then these education days like tonight, which we've been able to do over the last few years, and also support groups and retreats, which the greater cancer support community has been able to put on. So as I said, even though these feel like just a few hours or just a few dollars or just a few small little things we're doing here and there, they've really added up to be some really big projects. And one thing that we're always looking for is people that want to possibly tell their story. So we're partnered with a foundation called Kidney Can. They host fall and spring advocacy days. This is more of the legislative work, the ones that people are like, I could never do that. They meet with congressmen and women and senators to help petition to ask for more funds to be allocated into the national budget. So we really can continue to move research for this disease in the right direction. So in 2024, they've asked for $60 million to be allocated. If you remember when I said just a few slides ago, in 2016, there were $0. In 2023, it was over 50-some million. They can probably speak more to it than I can. People are always like very intimidated by this, and I can tell you from my mom, Joanne, she's also been very intimidated by this. It's out of your comfort zone, but these politicians aren't looking for you to be a political science expert or pharmaceutical industry expert or a finance person. We have people that do all of that. What we're missing is the story and the voice, what you're experiencing and how you feel. And that's what really helps to drive some of those results of creating $60 million allocated. So if anyone's ever interested in sharing your story, you don't have to be a medical professional, right? It could be as simple as how you were diagnosed, what you're feeling and what you're going through. Joanne and Melissa, you can find the one in the red. She'd love for you to work with us and join us in that mission. And it doesn't have to be in person. They have virtual or they have Washington. And so before I leave you with my final slide, I just want to say, as I said when you start, this might seem like this huge undertaking, but it really doesn't have to be, right? It starts with you and advocating for yourself and creating that awareness, but you can take it as big as you want. And as I said, you don't have to start on the steps of the Capitol building. I don't think Joanne or Melissa thought they'd find themselves there, but what do you see? Joanne and Melissa at the steps of the Capitol building. This is actually in Harrisburg. When they've been invited to Washington, D.C. for that work. It was over COVID more so they did those virtual. But these are two women that are teachers by background, right? They have no specific policy training. They really just believe in the cause, and they're willing to share their stories and the things that they've been through in order to make this mission a reality. And with that, I just want to share with you a few of the advocacy groups and resources out there. So whether you are someone that wants to be involved in stuff like this or not, whether you're in the middle of your journey or it's something that you've been through or you're here supporting a loved one, these groups, if you don't want to be a part of them, know they're here for you, right? And we're here for you for our foundations. There's a lot of different advocacy groups and resources out there. I pulled some that I find to be very reputable and have pretty solid information. So Kidney Can, that's one that we're partnered with. Casey Cure, Kidney Cancer Association, the Judy Nicholson Foundation, the National Kidney Foundation, Action to Cure Kidney Cancer. A lot of those are more of the advocacy groups, and then the NIH and the American Cancer Society do advocacy work, but I listed them here for their fantastic resources. So if you're looking for information or you have questions, I highly suggest checking out the American Cancer Society or the NCI. Or we have Dr. Ernstoff here from the NCI, so he can probably answer them for you too. So thank you so much for joining us, and I appreciate the time just to share a little bit about our story and welcome any and all of you to any of our events. We have a table out front with some more information, and if you would like to join us in some of our advocacy work, please let us know as well. I'm just going to draw the winner of the basket out front, so thank you to everyone that participated in that as well. Should we let Dr. Nair draw it? No, I don't want people to think I cheated. No, you draw it. You draw it. We'll let Dr. Ernstoff draw Eugene Mulligan, are you here?
Yes, he's in the back.
You won!
Yeah.
All right, do you want to leave your conclusions here?
So Megan, thank you so much. Any questions for Megan? Great job, Megan. Yeah, I did want, as we're closing the event, I wanted to introduce some hope for the future. One of my new colleagues, Dr. Amir Tor, Dr. Tor is our director of stem cell transplant and cellular therapy. So towards the end of Dr. Ernstoff's talk, a big hope for the future is really developing personalized treatments using your own T cells or off-the-shelf T cells, but really engineered to go directly in and attack the cancer. And a lot of this is getting much closer now. There was a big cancer research meeting, basic research meeting called AACR, and MD Anderson presented a study of 16 metastatic kidney cancer patients where they took a donor T cell off the shelf and they gene edited it to go find a protein actually on the surface of the kidney cancer. It's often a problem. Most of the things are inside the cell. This is called CD70. And 8 out of the 16 patients had strong expression of this CD70, and none of those 8 had growth of their cancer within a year. I think about 4 of them actually had shrinkage, and it was safe, but it requires a lot of expertise. So we've been on at least a 5-year journey to start stem cell transplants, allogeneic transplants, and what's called CAR T or cellular therapy. Dr. Tour comes to us with amazing experience. He was a full professor at Massey Cancer Center in Richmond, Virginia Commonwealth, and he's trained at University of Minnesota, worked at University of Arkansas, Loyola. In 3 months, he's really putting together almost like a dream team of nurse leaders and physician assistants, and we're working, day in and day out, and he has a great research mind. He actually wants to pick Dr. Ernstorff's mind before we leave, and then I think what I really want to leave is we appreciate all of you being so connected. I hope you got to share some stories with each other, made some friends. I think there's a really healing community, thanks, and the Durr Foundation is really our rock. And the Andy Durr Foundation, they have a great website, and they have a lot of events year-round. We have a wonderful Oktoberfest, which is not in October, but in September at Emmaus Town Park. It's very, very, it's a lot of fun. But there's so many other, my wife just said, she missed the arts and crafts event that they just had. So they have fun while they're supporting all of us. Our goal is to cure every patient with kidney cancer. Right now, it's in melanoma. We've been making progress. Kidney cancer, we've been making progress. I work in both cancers. Melanoma, the impact of immunotherapy has probably been about triple in terms of the actual cure rate. At our event last week, we had 50 cures of stage 4 melanoma. In kidney cancer, it's about 15 that I think are cured that are 10 years and out, without further treatment. We had hoped initially that it would be equal, but I think the VEGF, the blood supply, is really, it's one of many things, as Dr. Ernst, it's very complicated. But, I think with bright minds, with Dr. Ernstoff leading our National Cancer Institute's immunotherapy branch, all the work that's going on and everybody here, I think each year as we come, we're going to be making more and more progress. And Eugene, Mr. Mulligan, that won the basket, I'll end with him. Eugene was facing a very tough problem. Was that about, I'm trying to remember, Eugene, was that about 7 years ago? 7 years ago. So Eugene had the most aggressive type of kidney cancer, very rapidly growing, called sarcomatoid kidney cancer. It was around Christmas time. He had a nephrectomy, and I believe it was around 4 or 5 months later, he had a tumor the size of the original kidney. He looked at the CAT scan, it was almost like his kidney hadn't been removed. It grew back that fast. And at that time, the treatments for sarcomatoid kidney cancer was not very good. The approved treatments were the pills, the TKIs, or the medicines like Toracel. So the average survival was less than a year. It was very rapidly progressive and it tended to spread. Around that time, we were doing some work. Dr. Alison McIntosh is here. Alison, can you stand up because you're such a big part of our cancer program. You've treated so many of the patients here. So Alison is very, very modest, but she's brilliant. She trained at University of Virginia and really found that when you give a special type of radiation called stereotactic radiation or hypofractionated radiation, that's as Dr. Ballou said in English, it's it's small numbers of treatments, like 5 treatments instead of giving 30, but 5 at a medium dose, very tight corners, not huge. You release dead tumor protein, and then when you give an immunotherapy medicine, like nivolumab, in Eugene's case, the T cells get boosted. The radiation actually increases that inhibitory protein called PD-1, and so the T cells come in from the flanks. And so there had not been a single case report. What we were doing was really off-label, which we always have to be careful, Dr. Ernsthoff. Nowadays, when we have good science to drive it, so we actually got, insurance wouldn't approve the medication. We were able to get free medication for Eugene. We gave the radiation, and literally the next scan, it was almost going away, and it went away, and it's never come back. His story, along with the second case of a sarcoma, a different type of aggressive sarcoma of the thigh, where a patient was avoided amputation, also treated by Dr. McIntosh. We were the first group in the world to publish this about 6 years ago, 5 years ago. Since then, Dr. McIntosh has treated probably 300 patients in this, and she's part of a Memorial Sloan Kettering trial looking at this. And so I think it's going to be a lot of little gains along the way. And Eugene is part of our 15, but our goal is to get everybody there. So I hope you guys have a great night. I really appreciate everybody being here, and thank you so much.